Dr. Reed. So good afternoon, good evening, depending upon how you view the day. Thank you for joining. This is the January 11th meeting of the Maryland Primary Care Program Advisory Council. We welcome everyone in attendance and appreciate your time. We're going to move along. I would like to just acknowledge the folks that I've seen from the council. If I've missed someone, please identify yourself and we'll record you for the attendance. So joining us is Bob Atlas, Dr. Barr, Dr. Berenson, Alan, Dr. Haft, Kevin, Dr. Okiki, Jean Ransom, Dr. Reedman, of course, Scott Rose, our Executive Director, Ben Steffen, Chad Perman, and Alice from the PMO. Have I missed anyone? And now I see, good afternoon, I see Debbie Kuchka-Craig as well. So
David, Michael Barr just joined, so I'm late.
Good afternoon. Thank you, Dr. Barr, for joining. So that's everyone we have in attendance. So typically here we look to see if there are any operations updates. Melanie's going to make a few announcements and then we'll come back to you guys.
Dave, it's Scott Berkowitz. I just want to let you know I was on as well.
Okay, Scott, thank you for joining. Go ahead, Melanie.
Thank you, David. Good evening, everyone. So we want to remind everyone that this meeting is being recorded. In the event the meeting is breached, please hang up, and then I will send you an email through the MDPCP mailbox that will have a link that will allow you to log back in. The recording will always be available to the public. Please contact Anena or Melanie or send a chat message if you're having any technical issues. So you can mute and unmute yourself using the small button at the bottom of your screen that looks like a microphone. Please remain on mute when you're not speaking to reduce the background noise. Staff may mute you if there's a lot of background noise, but you can always unmute yourself. So you can use the chat function. It does send a message to all attendees. You cannot send a chat message to specific attendees using this technology. Please announce yourself when speaking. Everyone's free to speak throughout the meeting. There are a lot of people. We like to sequence the speakers if we can. So there's two different ways to do that. I'm not seeing the envelopes, but one way is to hold up an envelope where we can see it and staff will call on you. The other way is there is a small hand at the bottom of the screen. So you can push that and then we will call on you in order. The meeting facilitator may also call on people to speak to ensure we have a wide range of perspectives. So that's all I have. So I will now turn it back over to David.
Thank you, Melanie. I would like to acknowledge the addition of a council member here with us this evening. Will Daniel has joined us. So Will, thank you for joining. With that, I would invite our executive director, Mr. Ben Steffen, to make opening remarks, and then followed by the co-chair, Dr. Reedman.
Yes, thank you, David. I want to welcome all of the advisory council members. I think 2022 is going to be a pivotal year for primary care in Maryland as we look to move this program to a third track. And as we start to think about expanding the program beyond the Medicare population, obviously, when we talk about 2022, we're talking about laying the framework, but it's going to be key to the success of the program in 2023. We also look to continuing to engage the council. Part of the meeting today will be to really think about the work plan for the council over the next year. And I really want to encourage everyone to give some thought to that and to actively engage in those discussions. So thank you again for joining, and back to you, David.
Thank you. So Dr. Reedman, any comments you'd like to make at this point?
Yeah, I just wanted to first wish everyone a happy new year and welcome back. Say that I thought about this a lot when we were taking a break during the holidays, and I got to say, I felt like I got a lot out of the meetings last year. I think we accomplished a lot of interaction, a lot of feedback. I was hoping we'd have maybe more of an impact. I think that's yet to be determined, but the amount of work and the dedication and the expertise of the people on the committee, I found to be really interesting and informative, and I'm looking forward to more feedback and more comments from the expertise of the committee members. So I'm looking forward to our further conversations. I hope if y'all remember, I mentioned way back that my 3 decision points for this would it be fun, and did I want to, and would it have an impact? Well, it's certainly been interesting, and I'm still hopeful that we're having at least some, and hopefully some more impact on this. So I'm looking forward to the year ahead.
Very good. Thank you, Dr. Reedman. And I would like to acknowledge Dr. Baczynski has joined. He is a council member as well. And Nani, can you bring up the slide deck, please? And while we're waiting for this to come up, I would invite Dr. Haft to start off the presentation, and then follow up. Chad will step in and pick it up from there. But before we get started, there's a question from Gene Ransom. Gene,
I didn't have a question. I actually just wanted to thank all the state employees who were involved in the negotiations and all the members of the council for working on this. You know, we really were in a position where we could have lost this whole program. And I think that Steve Shue and Dr. Haft and Chad Herman particularly, and Patrick Dooley, who helped consulting, with a lot of other people who we don't always see, did a really good job working on it. And while it's not perfect, it actually is not that far away from what we had ironically originally proposed. But most importantly, it kept the program in place. And I think this is a really important program. I think it's really exciting to see investment in primary care. I think it has a chance at making a big difference in the long run to public health in Maryland. So I think we should really start by celebrating the fact that we're still here, and there's a plan to keep us here for a few more years, and we're doing something really neat and interesting and important for the public health of Maryland. So I just thought that needed to be said. Anyway.
Yeah, thank you, Gene. Great remarks, and they're echoed by many of us, and Bob just acknowledged the same comments. So thank you, Gene. With that, Dr. Haft, please proceed.
Good. Thank you very much. And first, Happy New Year to everyone. Wishing you a good start to 2022 and an even better end to 2022 for all of us. I'm very optimistic about that. And thanks to everyone who contributed to all the deliberations over the last several years. And truly, this is a pivotal time for primary care in Maryland, but it is also a pivotal time for primary care across the nation as we redefine the importance and the essential roles of primary care and the future healthcare delivery system that we'll be building to be responsive to the current threats and all future threats. And I'd just like to reflect back for a few minutes now on how we started this journey. It really began in 2015, if you believe it or not. And through 2015 and 2016, innumerable stakeholder groups and meetings and discussions with stakeholders in offices and in associations, and the work that MedCai did and many others over a year and a half came together with the original document that described what we would be doing here with what we're seeing now in 2022, many years later, as a primary care program as part of the next iteration of the Maryland model. And from the stakeholders, not from me, not from Chad, not from probably many of you, but as an aggregate of all of the input of many stakeholders over many meetings, we came up with 15 guiding principles. I think it's worthwhile just going back for a moment before we enter into the rest of the work for tonight, and just reviewing and see how close we came, how close we are now, and whether we're still in that same direction in terms of guiding principles. What we were told by primary care providers specifically should be the design for the future of primary care healthcare in this state. And it started out with person and family-centered care. I'd give us a strong rating on where we are now, where we've been, and where we're going with that is still really important and really central to everything that we're doing. concept of patient-designated providers. So this was a concept we came up with. Now we know that's more attribution and making sure that every patient understands that they have someone, really not just a provider, but a team that's responsible for their care in the model. And I think we've done pretty well with that also. It's not uniform. We've still got some ways to go, particularly in some practices more than others, but I think we're well on the way to that, realizing that guiding principle. Regional customization and flexibility to match local needs and leverage local infrastructures. This was really the birthplace of our CTOs. We said essentially that there are ACOs and clinically integrated networks and others who really know how to navigate around their neighborhoods and what they're using now and doing within their current structures. Some of them independent, like the ACOs, some of them coming out of hospital systems. But we wanted to make sure from the beginning that we utilize those resources. And, we did, and we still have CTOs, and they've become really an essential part of our program, as have ACOs in many ways. Steady movement from volume to value. Everyone recognized that we can't stay on this treadmill of having to see more and more patients for shorter and shorter times in order to meet the economic needs of the practices, and we needed to move to value-based payments, and we did that right from the get-go. We're still kind of feeling our way through what value-based payments should look like. There'll be ongoing controversies, I am sure, for years to come, and what that really means. Defining value and defining quality are very evanescent and challenging things to do. We said from the beginning this has to be an all-payer program, and that all payers need to pay in the same way and have the same design. Well, we're moving in that direction. We're not there yet. We're getting closer, I think, year by year. But I think that's still the ultimate goal. I'd give us a C- maybe where we are now, but moving up the scale from being a single payer program to now adding some more payers and closer alignment every year. Well, up to the next slide. So there were 15 principles. Those were the main ones. Let's talk about some of the others. Voluntary participation. We knew from the beginning we can't force people, primary care providers, and this is true, I think, for all of the national programs also. They have to be voluntary. Care management is a necessary element. When we started this, care management in primary care practices was really scarce. Very few practices did really boots on the ground, embedded care management, and now virtually all of them do. Provisions of evidence-based care, that was there to begin with. We continue to foster evidence-based care in as many ways as we can, and we're continuing to grow that as a principle. Sufficient and timely quality and utilization, financial incentives. Well, you can say that we pay up front for the quality, and then you get a deduction later on. So we do pay up front for that. I think we still have a ways to go in terms of being able to let our practices know where they are in terms of utilization and where they are in terms of quality mid-course, so they're not surprised a year or a year and a half later. So we're part of the way there. We still have a little ways to go, but the principle remains the same. Those things that best incentivize the behaviors that we know that we want to see are those things that are incentivized in a significant way, monetarily or otherwise, and done as close to possible as the behaviors that wants to be incentivized. So we've still got some lessons to learn there, but we're moving in the right direction. And providing financial and non-financial incentives for practice transformation. Certainly have done that with our care management fees and the PBIPs and others. And I think, our program could be better funded, but in many ways it's better funded now than many of the other programs nationally. The good news there is we're turning that better funding into savings and into better health for our patients. So that's exactly the intended effect. And that's what our providers told us from the beginning, is that if we provide better resources, financial and other resources, support resources like the PMO and like the advisory council and like CRISP and all those other things, that they can turn out a better product and save us money and save lives at the same time. And we're realizing that now. Aligned and consistent set of quality outcomes and utilization metrics, where I think we're doing that. Efficient data exchange. Here is probably one of the the most prescient things that our providers told us to begin with is don't give us 20 different versions of data from 20 different payers and then hope us to make some sense out of it. Let's put as much as we can in one place and make it useful, and using our colleagues at CRISP and that very powerful HIE that's guided by the Maryland Healthcare Commission, the work from Hilltop and the work of the coaches and the PMO. I think we are really doing that. We're providing efficient data exchange and connected tools for providers better than any place else in the country. And we were told we needed to do that. That's by our constituents, and that's why we're doing it. Quality and cost transparency for clinicians and patients. We're getting there for clinicians. I don't know that we're there for patients. I know that MHCC is making inroads to doing that, but there's still work to be done there. Avoidance of unnecessary utilization. Absolutely. This has probably been one of the hallmarks of the program, is that we can avoid unnecessary hospital and ED utilization. Duplicative services, we're still working on that, but the unnecessary hospital and ED utilization, I think this, with the guidance of our guiding principles, I think we've made every effort to do that, and it's been a roaring success. Recruitment and retention of primary care providers to address healthcare access. There, I would say we still have a ways to go. We have to make this the most attractive program anyone would ever imagine. And I think that will begin to attract more providers. It will attract more individuals who are deciding what they're going to do after medical school and put them into the queue for primary care, and attract more of those graduates from primary care programs to come to Maryland, because they'll recognize Maryland as the place to practice primary care. So we've got a ways to go for that. Those were our 15 guiding principles, and kudos to our stakeholders, to our primary care providers who gave these to us, and to all of the folks over the last several years since 2015 to now, who have made a lot of this really effective. So thanks to all of you.
So thank you, Dr. Hack. Are there questions or comments from the Advisory Council on the guiding principles presented by Dr. Hack?
Great. Thank you.
So seeing none, Dr. Reedman, I'd like to acknowledge the joining of the meeting by council members Stacia Cohen and Kathleen Logren tonight. So they have joined the meeting as well. So with that, if there aren't any questions or comments, we would like to proceed. And I think Chad Berman from the PMO will be presenting on, to start, on Track 3 PMO update.
Thank you, David. Can you hear me okay?
We can. Please proceed.
Okay, thanks. Happy New Year, everybody. Nice to see everybody back on the screen, but that's what we have to do. Yeah, excited to be back here with another year of MDPCP, and we have a lot to do and a lot to discuss this year for 2022. So let me start with the latest on Track 3. So we have a term sheet that's in with CMMI that was, I guess, given preliminary acceptance, and now it's going through their clearance process. So wanted to go over with everyone after we spent, I guess it was a few months ago, talking about what the terms likely looked like, what we ended up deciding on with CMMI. These terms, are still subject to change if CMMI comes back that they need to further negotiate any of them. But this is where we are, and this is largely, I think, the framework we will end up with. So first is the spending level. We agreed with CMMI that we wanted to see funding that was at least at the Track 2 level, and they were okay with that. So it will be budget neutral to the Track 2 level as of 2022, meaning the per beneficiary per month amounts as we move into Track 3 will be supported. So for practice, obviously there'll be lots of variation for practices. That will depend on the HCC scores of their beneficiary attribution, as well as the if and how much they get in terms of hard payments. Next slide. Okay, so some of the payments, which is a lot of the big change for Track 3, the population-based payment this is, you can think of this as the replacement for the care management fee. It's a practice average HCC score methodology that has 5 risk tiers. That's at the bottom of the slide. So practices we will determine the average practice HCC score for each practice, and then practices will be slotted into order based on percentiles. And depending on the percentile, similar to the way we have it in track 1 and track 2, they'll get a certain amount per beneficiary per month for all of their beneficiaries. So you won't have it where beneficiaries have an individual PBPM and then it comes out to an aggregate amount. Every beneficiary in that practice will receive the same amount in terms of a payment per beneficiary per month. Early estimates with the analysis with CMS suggests that those numbers will be somewhere between $50 and $80 for the different tiers. But not until we get the practices determined for track 3, probably summer, fall of 2022, will we know the actual amounts for these groups. Next slide. Okay, so the next payment, which we're starting with this year in 2022, are the HART payments. We're going to have HART payments in track 3 as well. And the expectation is that those payments will be similar or the same level that they are going to be in 2022, which is estimated to be around $110 per beneficiary per month. And remember, HART payments are only for the beneficiaries that meet the criteria that's listed here. So they have to be one of the 2 highest HCC risk tiers, either the moderate high risk or the high risk, and also at the same time have to be in the highest quintile of ADI scores for the state. So when we did an initial analysis, that was about 6% of the beneficiaries ended up fitting in there and generating or triggering a HART payment for the practice. On the other hand, because the HART payments are new, CMMI does not want to put the HART payments at risk for either the practice or the CTO. Next slide. Okay, and then we have the flat visit fee. So this is the essentially a replacement for the comprehensive primary care payment in track 2. And it's going to be based on the weighted average of the list of select primary care services that are used for the track 2 comprehensive primary care payment. So it's a set of mostly E&M codes, and that will determine the amount of the flat visit fee. In CPC, or not CPC, in Primary Care First, the national program, the flat fee is around $42. We expect it'll be a little higher in MDPCP, but we don't know that amount yet. And again, they won't calculate that until the summer or fall of 2022. They also will have an adjustment for facility versus non-facility locations. CMMI did agree with us that, at least at this point, that a practice could bill for more than one E&M service in the same day. In the national program, they don't allow for that. And then a coinsurance will for the patient will still be at 20%, and it'll be 20% of the allowed amount, not the flat visit amount. So if the allowed amount for a particular service is $100, it'll be 20% of $100, not 20% of whatever the flat fee is. And then they do apply a geographic adjustment factor. Okay, and then performance, quality, utilization, cost. As you'll recall from the national program, they use something called a PBA, a performance-based adjustment. So instead of having a flat PBIP, we will have a percentage adjustment based on the scores of the practices in quality, utilization, and cost. And some of the priorities are we want to continue to incentivize performance. We want to avoid what happened this past year where we had practices beating the benchmarks and receiving no adjustments or even receiving negative adjustments. And we also want to try to the degree possible within the criteria and the formula, mitigate the number of practices that are receiving negative adjustments. CMI did agree that they would provide feedback reports on a quarterly basis. So the utilization and cost data that's assessed every quarter, practices would receive a feedback report on that so they know how they're doing and can identify opportunities for improvement. And then on an annual basis, we would have the cost and utilization data. We'd also have the quality and patient experience data, and that would come in an annual report. And then in terms of timing, they'll obviously have to look on past performance to make future adjustments. So I think that we'll have a sort of chart to show what that looks like for practices. And then in terms of the quality measures and the benchmarks, all of those will continue to be prospective unless otherwise noted. Next slide. So we got to the point where we agreed with CMMI to keep as much as this structure consistent with tracks 1 and 2 to make it easier for practices to understand and try to continue on the progress they're making. So same measures, same structure. 50% of this would be quality based on national benchmarks. We'd have the diabetes control, the diabetes prevention, hypertension control, a behavioral health measure, and then the patient engagement piece for quality. On the utilization side, that will continue to be 25% of the performance-based adjustment. The benchmarks on utilization and cost are Maryland, and we'll have acute hospitalization as well as emergency department utilization. So same measures, HEDIS measures there. And then 25% of it, which we're doing now, will be for cost. That will be the total per capita cost measure. Next slide. So in terms of the framework, it's an asymmetric risk framework. So there will be a downside potential of negative 10% for the lowest 10% of practices would be subject to that. And then, but all the way up to a positive 25%. And the measures are going to be assessed individually. So that's how it'll be calculated in a combined format for all of the measures. You can see that it's there's negative 10 and negative 5% adjustments, and then there's a large area with no adjustment. And then at the upper end, we want to encourage obviously strong performance. We have 5%, 10%, and 25% upside. Next slide. So related to all this is level risk and advanced alternative payment model status under quality payment program. So as you recall, the issue that we ran into this past year, all practices, the interpretation is all practices have to have at least 5% of their revenue at risk for the medical home model AAPM status. So in order to do that, CMMI insisted that we have all practices subject to at least 10% risk to make sure that they hit the 5%, because everyone has a different denominator of revenue. So we wanted to make sure we didn't have an issue with that again. Practices, as you know, that have over 50 clinicians that are part of larger organizations are not eligible for the medical home AAPM status, but they will be subject to the same PBA and will be required to meet the nominal risk standard to ensure that all practices in the program can qualify for AAPM. And then on the Medicare shared savings practices, they will receive the full population-based payment, but will not be subject to the performance-based adjustment. CTOs. So CMMI agreed that CTOs are a fundamental part of the program, and we'll keep them in here. CTOs will receive a share of practice payments, same way they do today, paid directly by CMS, and that would be the population-based payment and the HART payment. And the population-based payment is the piece that would be subject to the performance-based adjustment. In terms of, we want to make the revenue that flows to the CTOs as close to what it is today. So CMMI has done some analysis and believes that that number is going to be, and they'll have to recalculate when we get the final numbers, is going to be around 40% for those that are currently doing a 50% option, and around 24% for a 30% option. The The payments and the population-based payment are a combination of multiple payments that are in track 1 and track 2, so they're actually higher amounts. And then CTOs will continue to operate as they do in signing participation agreements with CMS, and then also having a CTO practice arrangement with the practices. Okay, and then last major areas, participation options and the timeline. And apologies, we squeezed a lot into this slide. So first thing is in terms of a request for applications, there's going to be 2 more. We got one coming up this spring in 2022 for 2023 participation. And then there will be one more RFA in the spring of 2023 for 2024 participation. That is for practices and CTOs and FQHCs that are not currently in the program that want to come in. If you're already in the program, which we think the vast majority of practices and CTOs that are going to participate are in the program, they would go through a transition application, which would be similar to what we do right now from track 1 to track 2. In terms of transition timelines, practices may apply to track 1 in the response to the 2022 RFA to start in 2023, but 2023 will be the last year for track 1. So after that, practices will need to move into track 2 or track 3. And you can see here in the table, we've outlined the column on the left is a year that the practice began in track 2. So for 2019 and 2020 starters, the first 2 rows, the requirement is for those practices to move into track 3 by January of 2023, meaning those practices probably will have to complete a transition application this year in 2022 in order to move to track 3. After that, it'll be 2021, it'll be 2024, and so forth. And then for track 2, the plan at the moment is that the final year operation for track 2 would be 2025. So by 2026, all practices that are in the program would have to be in track 3. We are still working on how we will do it for FQHCs. FQHCs have just moved into or had the option to move into track 2. We did not have time to work through what the methodology would look like for FQHCs and the PPS system in track 3, but we will be working on that with CMI over the next year. And I think that is it on track 3. David, do you want me to keep going with the other updates, or do you want me to stop for track 3?
Why don't we pause for a moment? Thank you, Chad. It was an excellent overview of the track 3 term sheet. It's a lot to absorb. I sort of feel like everybody needs to take a breath for a moment and go, okay, what questions do we have for Chad or others that have been part of this process? And let's start with Kevin. Kevin Hayes, good afternoon.
Thank you, David. And thank you, Chad, for that very, very clear presentation. Really appreciate it. I have one question about slide number 8. There's a bullet there on cost sharing. And the way you described it, it sounds like cost sharing will work pretty much the way it does now in terms of 20% of allowed charges, if I understand that correctly. But there's a mention in here of a reduction factor to ensure cost sharing neutrality. And I wonder if you could say a few words about what that is and why it's necessary.
Kevin, good catch. I should have taken that bullet out because I think I've created more confusion. As part of the formula that CMS uses to figure out the amount for the population-based payment and then also the flat fee, they use a reduction factor to ensure that cost sharing for beneficiaries will be relatively the same as it is today. But in effect, it's that bullet down at the bottom that I talked about. It's still 20% of the allowed amount.
Okay, got it. Thank you.
Thank you.
So there were a few comments that were received along the way. Melanie, are you able to read them back?
Yes, David. The first one, you mean in the chat function that people sent in the chat function?
That's correct.
So the first one was just a ditto for earlier, but Jean said we need to do some education about the HARP payment to the physicians. Obviously, we should wait until they get funding levels at the end of the month, but I expect there's some confusion on how that will work. And Vivian, who I believe is with the PMO, said, in the meantime, here's the link to the upcoming HARP payment learning session registration. There's a link there and the date and time. And then Jean said, thank you. That's very helpful, and MedChi will promote.
Dr. Reedman, any reaction here? Okay. Dr. Baczynski, good afternoon.
Hi, good afternoon. Quick question. Maybe everyone else knows this because you all are more familiar with policy than I am, but the flat visit fee, does that just apply to the E&M 99213, 99214s? And at that visit, you could still bill for, say, smoking cessation counseling or a joint injection or some other non-E&M service? Or is everything you render during that visit come under that flat visit fee?
Dr. Baczynski, I think I'm pretty sure, but we'll have to get the methodology out for you. I'm pretty sure you can still bill smoking cessation or something else. We were told it's largely for E&M, but it includes a few other codes. It's, I don't know, 30 to 40 codes. We can pull that together and get that for you. But the idea is that it's supposed to simplify billing. We're not sure if that is really the case, but that if you bill for a particular 99213, you would automatically receive the flat visit fee amount for that. But if you also billed for smoking cessation, you would also get paid for that at the allowed amount.
Okay, I'd be interested in what codes end up, collated under that flat visit fee. Thank you.
Yep, thank you.
Other comments or reactions? And just for the commenter who asked about the slides, we do post this material on our website, so it will be available there to the public as well. Seeing no additional comments or hands raised, Chad, please proceed. But I would ask, Chad, if you're comfortable taking questions along the way on this next section, that you invite the council members to raise questions at some point on each slide, as opposed to the end. That works for you.
Yeah, that works fine. Thank you. That makes sense. Okay, so let's go back. Let's go down to the annual report update. Up one. Thank you. There we go. Perfect. So just wanted to thank everyone for their input and support in putting together the 2020 annual report. We submitted that to CMMI early December, and they're currently reviewing it. We're awaiting feedback. But just the highlights from what's in there, we highlighted that 4 major areas of continued progress in MDPCP. So one was infrastructure. We continue to have a larger and larger program with supporting partners, with an advisory council, with CRISP, et cetera, that's addressing medical, behavioral, and social needs. And it appears to be effective in, to date so far, reducing utilization and helping the state in meeting its total cost of care obligations. Certainly, the program is doing a lot in care transformation, addressing the health of the Medicare population and other populations that are being served in the practices, and continue to address unnecessary and unavoidable utilization, as well as follow up after hospital utilization. And then quality and utilization improvement. We have established data tools to support practices in that. Practices are developing their own tools as well as with their CTOs, and are putting in QI processes to allow practices to monitor that performance. And then obviously COVID-19 hit in March of 2020. So we couldn't avoid that, and we couldn't ignore it. And practices have done really an amazing job in quickly transitioning to telehealth, to proactive outreach, to therapeutics, and now to vaccinations. We have around 450 practices, I believe. Is that right, Dr. Haft, that are currently vaccinating in Maryland, primary care practices, and almost 300 of them are part of MDPCP.
Yep, I think that's right.
Okay.
Been a critical infrastructure piece for the vaccine program and the therapeutics program and testing.
And testing. Thank you. So the links to the annual report are in the final bullet. And then we also break out the full report versus the executive summary, as well as some snapshot slides if you want to have a few slides to look at with your colleagues that review the report. Any questions or comments on the annual report?
Chad, could you just note where the public who are listening in could access that report, please?
Sure, and maybe somebody can add into the chat box there. It's at our website, health.maryland.gov/MDPCP.
Okay, and we'll get that and share it as well.
Great, thank you. Okay, and then an update on participation for 2022. So we had 525 practices for 2021. We've had a few practices leave, and we've had several practices that have either merged or been acquired by other practices in the program. So for 2022, we are now at 508. So nothing to sneeze at, but a few lower than we had last year. That includes 7 FQHC organizations that represent 44 individual locations. We still have 24 CTOs, so quite robust. And then a great sign of progress in the program is that we now have 88% of the practices in track 2. So you remember we started year 1, 2019, with 90% of the practices in track 1. And each year that's moved a little bit. As of 2021, it was about 50-50. We've had a significant number of practices for 2022 transition to track 2. So we're very proud to see that. We don't have the attribution number of beneficiaries yet for 2022. We expect that it will be out probably at the end of January. As of the fourth quarter of 2021, we had 373,000 attributed beneficiaries. And at the same time, we had a little over 2,100 providers in the program. Any questions or comments on participation?
Chad, it's Debbie Kuchka-Craig. I was just wondering, of the reduction, were any of them because they didn't make the requirements for track 2? Because, you know, this council's been concerned about readiness and the progression. It's good to see the 88%, but I was just curious about the delta between where we were, other than the acquisitions that you mentioned.
Yeah, no, good question, Debbie. Alice, correct me if I'm wrong, but I believe every practice that requested transition made it. I don't think we lost any practices for that reason. So kudos to you and your colleagues. And Alice confirmed. Thank you, Alice. Okay, next slide. David, are we here yet? Or are we taking a break now?
Okay, so let's just pause for a moment to see if there are any other thoughts or comments regarding the presentation of the annual report. Okay, seeing none, I think it's fair to proceed. So our executive director, Ben, are you looking to see if you're able to sort of tee up this this item?
Yeah, thanks, David. I don't think necessarily it's a lot of teeing up. What the Medicaid administration is working to develop a proposal in collaboration with the MCOs in the state that would fit the Medicaid managed care population into the MDPCP program. The negotiations are ongoing, and we had hoped that we could open up that discussion today to the advisory council. Unfortunately, there's multiple meetings going on simultaneously, and the Medicaid leadership is participating in those meetings. So we decided to defer these discussions until they could be present rather than speaking on their behalf, which certainly staff can do, but given the nature of those negotiations going on right now, it's better to have Medicaid staff leading that discussion going forward. I'm very optimistic that this is going to be worked out as over the course of the next several months. The actual nature of it is still very much in flux. Likely there'll be a good deal of flexibility for MCOs to participate in the program, but we look forward to getting bringing the advisory council into briefing them on what's going on and getting their input, but we'll have to wait a couple months.
One question, Dr. Baczynski, please proceed.
Yeah, thanks. Quick question. Is negotiations with this occurring just at the state level with state Medicaid, or is this subject to CMMI and federal oversight and approval, or can we just negotiate something here at the state level?
It's going to be with CMMI and actually Medicaid, CMS Medicaid active involvement as well. So it's not something the state can simply do in discussions with the MCOs. It will require CMMI participation as well.
Thank you very much.
Question. Any other questions for Ben here? Okay. Next slide. And Ben, if we could keep you engaged for a moment, that would be great.
Is Chad going to lead that off, or is this something that you want me to kind of?
My apologies. I should have clarified. Ben, we were hopeful that you could sort of take a point and then see if others want to make any comments.
Yeah. So I think this is even, there's beginning to be some thinking about how the Medicare Advantage population and managed care organizations could potentially participate in the MDPCP program. This has been interest of the health secretary, and obviously there are challenges here in the state. Medicare Advantage has not taken deep roots in Maryland up to this point, although there are reasons to be enthusiastic. Certainly some new participants, Care First being one of those, joining, adding a Medicare Advantage program does offer some possibilities, but there are some historic challenges. As many of you know, participation in Medicare Advantage in Maryland is quite low. There's a number of factors that folks point to, including large numbers of federal employees that are retirees that are limited in the Medicare Advantage plans they can join. The Maryland hospital model, longstanding hospital model, some have contended is not conducive to the Medicare Advantage program, and the options that are available are not available through all parts of the state, meaning that participants, Medicare beneficiaries that might be interested in joining a Medicare Advantage program don't have as much choice as they do in other parts of the country, and certainly compared to some areas of the country, what the additional benefits, those things that you hear Joe Namath touting every evening in terms of additional benefits for vision care, dental care, and prescription drugs, have not been MCO or managed care organizations offering advantage, the advantage benefit, haven't been able to offer those to the same degree they have as in other parts of the country, meaning it tends not to be as attractive to Medicare beneficiaries as elsewhere. All of those factors really contribute to the fact that we have relatively low uptake, but we are looking at potentials for expanding the program, as well as in conjunction with that, aligning potentially the Medicare Advantage program with the MDPCP program, at least philosophically. And here, if we look at programs across the country, the opportunities to use Medicare Advantage with an advanced primary care program would offer some benefit to supercharge some of the care management features that are available through both programs. There are also some areas for perhaps aligning some of the quality measures, although we have to keep in mind that Medicare Advantage is a program unto itself in Medicare, and it's unlikely that CMS is going to agree to a significant kind of transformation of Medicare Advantage to the benefit of the Maryland model. But there certainly are potential here for some discussions, and I think the fact that we have some payers that are actively engaged in MDPCP now involved in the Medicare Advantage space gives one some opportunity for optimism. Work is just getting underway here, and it's probably just at the thinking stage is where we're at, but we wanted to kind of tee this idea up a little bit with the advisory council. It's something that I think even some of the Medicare, the CMMI leadership looked at and said, interesting, but it will take some thinking on everyone's part to create the kind of alignment that would be beneficial to the Medicare population, as well as providers in the MDPCP model and the Medicare Advantage payers as well. So I'll stop here. It's kind of a meandering discussion that I've given you, but it does shed light on the fact that state leadership is trying to be as creative as possible and trying to build some synergy across various legs of the Medicare program to the extent we possibly can. There's certainly no guarantees here that this can be done, but it is worth thinking. And given we have some folks in this council that have come up with creative formulas in the past, we thought it was an opportunity to at least suggest that we think about it together.
Thank you.
I'll pause here. I'll actually ask the MDPCP PMO team to see if they have any additional comments or ideas before we throw into open to everyone's. Chad,
Yep.
Dr. Happ.
Ben, yeah, I'll just add, Ben, that the one immediate option that's available to MA plans, like any other plan, is to potentially participate as an aligned payer, similar to the way Care First is an aligned payer, and similar to how Medicaid MCOs are looking at potentially participating starting in 2023.
Thank you, Chad. Dr. Happ?
No, I just echo what Chad said. There's always the opportunity to apply as an aligned payer, and I think there's some really great opportunities for Medicare Advantage in that if there can be a good alignment, the Maryland Primary Care Program can serve those constituents that would be enrolled in those plans and serve them well with good outcomes and savings, and that becomes a win-win situation for everyone. So I think there are some opportunities. It would really depend on the degree of alignment, though.
Thank you, Dr. Happ. So any comments or questions for Ben or the PMO from the discussion on the Medicare Advantage alignment? from council members? Okay. Seeing or hearing none, Anani, can you click ahead one slide? What I'd like to do here, oh, we do have a comment. So let's go back a slide, Anani, and Stacia, please ask your question.
My apologies. I wasn't fast enough on my clicker to unmute myself and raise my hand at the same time.
No
You know,
worries.
I think there is certainly some good possibility around Medicare Advantage alignment. Frankly, I think the more we have all the people rowing in the same direction together, the faster practice transformation and outcomes can happen. I think you highlighted a couple of the areas, though, that I think are going to be problematic that may lend themselves better to aligned payer arrangement, and that is there's no way Medicare is going to release the Medicare Advantage plans from the Medicare Star program, and that is critical to even being able to do Medicare Advantage. If you can't, and that's frankly why lots of plans in Maryland have struggled, because you don't have the quality bonus payment that goes with the STAR program, and you're starting at a lower benchmark. So I just think for this council to know sort of what some of the long poles in the tent are might be helpful for folks. I think that the specific quality alignment is probably one of those areas. The other one was one that Chad, when you were talking through the heart payments, I don't know if that would translate to the Medicare Advantage market. I don't know that you can selectively give benefits in that way in Medicare Advantage. That's certainly something I think that would require some additional research, and you certainly can't waive cost sharing on it. You've got, there's a lot of rules around that, and you have to be able to predict it in advance to file it in a bid. And so I think perhaps some of the, sort of bid timelines and those things could be a bigger barrier to, practically bigger barrier to what I'm sure many would say is, oh, well, we should do it just the same. I think we probably won't be able to, but it's definitely worth some investigation.
Yeah, those are very good comments. Thank you, Stacia. So any other comments in case that we were advancing too quickly for some of the council members? Okay, so Anani, let's go to the next slide. So here I would just note that the great presentation from Chad, Dr. Happ, and Ben, well appreciated. It seems like as a council, we will have opportunities to weigh in on several items potentially, but it could turn out that track 3, the PMO requests input to specific questions or comments or areas raised by CMMI at some point over the next few months. We could also have opportunities for weighing in as it relates to any sort of model that the department might recommend for the MCO alignment. And I think we've heard Stacia and Ben acknowledge that there's opportunities but challenges with the Medicare Advantage program. Here too is an opportunity. So my purpose for stating that is that while we don't have specific meeting dates on the calendar, we likely anticipate having another meeting at some point in the first quarter. But I think these meetings are really pending on any issues that emerge that require council input. We do plan to keep you updated through just general announcements as well, based upon what we learn that can be shared. I'm happy to do that. So here I would like to pause and note that, well, let me stop for a second. Stacia, I think you had a question?
Just when you open it up for general questions, I have one.
Okay. I would just acknowledge that before we move on the agenda, that we weren't necessarily counting on using the full time allotted tonight. So it will turn out that we are able to free the council earlier. But just in terms of process, we'll invite Stacia to make a comment, and if there's anyone else that works well, we'll then turn it back over to Dr. Reedman for a comment, and then to our executive director, Mr. Ben Stafford, for remarks. So, Stacia, please proceed.
So I just had one quick question, and it's possible you covered it in the first couple of minutes because I was a few minutes late today. It maybe is a Captain Obvious question, but if in fact we do all these things and Track 3 is approved in this way, does that mean that we get the AAPM status back for all of the participants in MDPCP in 23?
Great question. Chad, can you respond, please?
Again, that is a good question. What's been designed for Track 3 is designed to get AAPM status for Track 3. We still need to develop an update and a proposal for CMMI, which we're supposed to do in the first quarter of this year, to increase financial risk in Track 1 and Track 2 in order to get AAPM status for those tracks.
Okay. And is there, Chad, is there a time clock we're ticking against to make sure that gets done in time to meet 1/1/23 payment dates?
They're telling us they need something. They need to iterate with us and have a proposal in by the end of February. And then they have to run it through clearance and get approval by the spring, so they can then include any updates to the RFA that would come out in probably May or June.
Okay. So we, as a council, have weighed in on all the things you need us to, to weigh in on to advance that in order to get that done by the end of February. I just know that that's a timeline is always a challenge with them, and making sure we can meet their timelines.
Yeah, no, you're absolutely right about that. So we are in the process of getting some analysis done by our vendor, data analysis, and then we have to go to CMS and find out, what are the parameters of the risk options.
Okay. If there's anything you need from any of us, I'm sure that we're willing to put together a fast call between now and then, should that be necessary, so we can ensure staying on track for that.
Thank you very much.
Thank you, Stacia, for bringing that up. And just my understanding, Chad, from our prior conversations, that the biggest issue is we got to hit that 5% threshold, and that's the biggest thing, and that's really what you guys are working on, right?
Exactly. Yep.
Okay. But that really good point. I'm glad you brought that issue up.
Okay. Dr. Berkowitz, then, Dr. Haft, then Dr. Berkowitz.
No, I defer to Dr. Berkowitz first. That's fine.
Okay. Thank you. Dr. Berkowitz.
Just a quick question. Thanks again for all the effort and for sharing the materials tonight. I know that you mentioned with respect to the slides that they would be posted but not circulated before then, I think may have been suggested. When do you think that they'll be posted?
Tomorrow. And that typically, we were just a little slower getting them finalized, so our apologies, but they'll be available tomorrow.
Okay, great. Thank you.
And what we'll do is, to make it easy for the council members, we'll just recirculate them to everyone, so they'll show up in your inbox and you won't have to look for them.
Thank you so much.
Sure. Dr. Haft.
Yeah, thanks. I just wanted to say that I was honored to be able to lead off with the guiding principles that we established even well before the program began, based on input from stakeholders. But one of the things that I think has really shown even more brightly over the course of this pandemic in the last few years was how critically important the role of primary care is in our very broken healthcare delivery and payment system. And Maryland is given the opportunity by happenstance or for whatever reason to really make a big difference, both in the payment side and in the healthcare delivery side, and to use this model, this primary care model, as an example for the whole nation. We shouldn't take that lightly, either on the payment side or on the healthcare delivery side. So I believe that we're probably going to stand out as extraordinarily unique compared to the rest of the nation in terms of models. And that is a weighty responsibility that I think the advisory council, through all of the various lenses that they see the world, whether it's a payer lens or a provider lens or a regulator lens, needs to take into account, because a lot hangs in the balance. We don't have much hope based on what we see now in front of us for major changes in the way we deliver healthcare and pay for it in the nation, and we're on a trajectory that doesn't look still very positive in any way, shape, or form. So I think making bold moves, making bold statements, putting a lot on the line is really what is going to be necessary for us and for the state for the future. That's all.
Well put. Thank you, Dr. Haff. And before we turn it over for closing remarks, Melanie, are there a couple operations announcements that you wish to make?
I think you saw my two big ones, David. So the one is that we post the video and the meeting materials up to the advisory council page that's on the MHCC website. And then you also talked about the future meeting dates, which are the two big things. If anyone would like any additional administrative items, they can always reach out to an NARI if they're unable to download something off the site or something like that.
Yeah, and if Melanie, if we could just send the slides to the.
We'll just send them out to everybody tomorrow. So, yeah, we can do that for sure.
Thank you, Melanie. Ben, any closing remarks that you would like to make, and then we'll go to Dr. Reed.
Just after Howard's bold admonition, I think that I'll leave that sticking in everyone's head. I think we do have a grand opportunity here in Maryland, and we definitely want to make the best of it. Clearly, we're a little vague about the advisory council's work plan over the next year, but we definitely, as the issues take some root, we intend to engage this group fully and get your input. So I want to thank you for attending tonight. I want to thank David and his team for the work in putting this together, as well as the PMO for their steadfastness in supporting the program over the last year. So thank you very much, everyone, and have a great evening, and look forward to seeing you at the end of the first quarter.
Thank you, Ben.
Thank you.
Dr. Reedman.
Yeah. First of all, thanks again, as everyone said, for the participation. Howard had a comment on one of his slides early on that I think I'd like to double back to, and I think it emphasizes how critical these programs are and how critical the improving the appropriate reimbursement for primary care is. We're having an increasing difficulty as a group trying to find physicians, new primary care physicians. It's hard to recruit them. It's hard to get people to go into primary care. And I think these programs that we're looking at are going to be critical to improve the quality for the patients and for the primary care physicians. And if we're truly going to recruit physicians out of med school and residency programs into primary care, programs like this are going to be instrumental. So I think it emphasizes how much we need to do and how much importance these programs carry and how much weight they carry. Other than that, again, thank everybody for the comments. I have to say, I see Bob on his face there. I was listening to WTOP the other night and on the way home, and they said they had an expert, and I said, I know that voice. So it turned out that Bob was the expert. So I heard you on WTOP the other night.
Well, I hope you didn't think
myself on WTOP. What was my topic that I was expert on?
I did hear that one.
I think he was talking about me. Are you talking about me? Or?
I'm sorry, it was Bob Atlas. Sorry.
You're both all the time.
You're both stars.
There's only so many Bobs left in the world, but where there's two of us here. Yeah, well, since you mentioned me, I'll just say, I've been kind of quiet this evening because, COVID is drowning our hospitals. Believe it or not, we went down 8 inpatients today. Woo. But we're still 1,500 above the all-time high from a year ago. So it's really bad out there, guys. And you all are influencers yourselves. So please, tell everybody it's real. Do the right thing. Don't go playing in the Australian Open without a vaccination, etc. And hopefully this will peak in But we did have, I'll just let you know, we're up to 14 hospitals that have declared crisis standards of care as of now. So it's serious. Thank you.
Thanks for your help, Bob Atlas. Sorry. I look forward to our next meeting also, and everybody have a good evening. And I guess we'll sign off there unless you have something else to add, David.
No, I think this is a good place to end. Thank you all for your time.
Thanks, everyone.
Take care.
Everybody.
Good night. Thank you.
Good night.